1 year, usually less, half a year, you have swelling pus. You open the flap and you see cement, you clean it, and this is the early periimplantitis. What about the late periimplant disease? When you have bone loss, let's say after 4 or 5 years of loading, then you even have been forgotten about cementation of that wound. You might think that maybe infection, overloading, all other factors except cement. But there is data that, like in his case, when you open the flap, you see how much cement is left after cementation. It's cleaned, and the case is resolved, and implants are saved. Funny, but there is the other way. There is sometimes you can find cement, but no disease. Like here, you can see a mechanical complication, fracture of porcelain, and it's clear that you need to replace this crown. You take this out, and you see what you see. Two things. You see a crown with load of cement. Of course, you cannot see it in the X-ray, but what amazes me is look at the tissues. They are perfect. But still, these things raise many questions, and I think we need to find answers for them. One of the mostly quoted studies in recent years in implant prosthodontics is this case, a study of Wilson, which showed association between cement and periimplantitis, the late periimplantitis. And the author concluded that he found this periimplantitis from range for 4 months till 9 years. So what are the reasons why some patients have periimplantitis very quickly, some have delayed or even no disease at all? So this is the question. So here we tried to make a retrospective clinical study and try to answer this question, like to determine the relationship between patients with a history of periodontitis and the development of cement-related periimplant disease. Maybe that's the key. Maybe that's the answer to the question why some patients develop periimplantitis and some not, because maybe they are periodontally, with the patients with history of periodontitis are more prone to do that. So this is the course of the study. We have it sample size with for patients with complaints in regular maintenance. The complications we had were biological and mechanical. Then we looked there was cement or not, and then whether the patient had history of periodontitis or no history of periodontitis. So first of all, biological complications. We divided them between perimucosite, periimplant mucositis, and periimplantitis. Then mechanical complications, all incidents which required removal of the restorations. This is the reason why we included them, because we're able to see whether there was cement there or not. Because as you know, in X-rays we cannot see nothing, and extensive fractures, framework fractures, screw loosening, in those cases we could take restoration out and see where there is cement or no cement. And again, one of the most important parts of the study to detect whether there was cement or not. So in case we visually saw the cement, like in this here, we take out restoration and see, they were grouped with a positive answer. And in some cases where we could not remove the restoration, we raised the flap. And if we did not find any cement, so this case was selected as a negative, as a no cement remnant. And then the same patients were looked whether they had history of periodontitis or they did not have history of periodontitis. So here are results of our retrospective study. 77 patients were included. We had such amount of biological, mechanical complications and such allotment of patients with history of periodontitis or no history of periodontitis. And here is also distribution about within cases with semen remnants and implants with semen remnants between patients with history of periodontitis or no history of periodontitis. So let us stop a little bit more closer to these results. And these are results of the cases where we actually found cement, where we saw it. So if the patient had history of periodontitis, it was practically 100% periodontitis involvement. There were 4 early periodontitis cases in both groups, so we excluded them, and I will explain you later why we did that. In the group where we found cement, but those patients were young and no periodontal involved, there were 11 cases where we found cement, but there was no any problem, not even perimucositis, like I showed in the beginning, in the introduction. There were 20 peri-implant infections, but those were perimucositis, meaning less severe inflammation compared to periimplantitis, which is bonus. Other part, in some implants where we did not find cement, there also were cases with periimplantitis or no complications. Probably in these cases the periimplantitis occurred due to different reasons, or another one that the cement may be washed out during the time. We cannot explain that. To be completely sure that this data is worth continuing and working, we made a control group. It means we gathered patients with the screw retained, meaning that there was no cement involved at all. And again, split it then between history of periodontitis and without history of periodontitis. And in one group there was 185 implants and the other was 53 implants. And look, this is the percentage of per-implant infection in those groups. Meaning that with patients with history of periodontitis, there was problems, but those were not due to cement. In patients without history of periodontitis and which they received screw-retained restorations, we did not have any problems. So, in the part of discussion, I would like to bring a chart to you, and meaning like to summarize all the ideas, all the data we have, and to maybe get some explanation why maybe we can see the patient which might develop periodontitis due to cement. So first of all, I think it's important distance to bone. Why? Because if it's close to bone, in that case we receive early periodontitis, and this was known, and it's nothing new. It was there are several papers published about that. As I told, acute periodontitis, swelling, you remove restoration, you clean, and the case goes on. The other part is when cement remnants are somewhere in the sulcus. I mean, the distance, you cannot control it, but let's say it's not close to bone, somewhere between bone and the outer thing. And here, I think, the history of periodontitis, whether that patient is perio or not perio, might be important. Because if it's patient with history of periodontitis, he can develop periodontitis. And you know that in periodontitis it takes a lot of time for calculus to form and to be periodontitis development. But in case of periimplantitis, we can do it in 5 minutes. Like here you see, it's because cement, it's like artificial calculus. And the recent statement is that there is no etiological association of subgingival calculus periodontal disease, but it acts like predisposing factor. So maybe we could look at cement remnants in that way, that there is no etiological association of cement remnants and periimplant disease, but it acts like predisposing clinical factor. So if we go back to our chart and see, let's say you have a patient with history of periodontitis, it is likely that he may develop delayed periimplantitis. Like here, you see history of periodontitis, teeth removed, lot of implant placed, but after 5 or 4 years, you see one implant, there is a periimplant bone loss, and then you open the flap, you see, find cement, clean it, and the case is like this. If patient has no history of periodontitis, it might be likely that, like in here, which I showed you, there might be nothing at all. I mean, that cement may reside there, let's say, for many, many years, and neither the patient nor you could even thought about it. Or it may be delayed perimucositis, meaning after many years, there still might be some infection, some inflammation, but possibly of a lower severity compared to periimplantitis. Of course, you cannot say that perimucositis could not develop into periimplantitis afterwards. Why it is important? Because it's a little bit connected to the lecture, the first lecture I spoke today, that we think that we clean the cement, and we want to believe it. We want to believe it because we don't see it, patients don't see it, X-rays don't see it, so it means that it's gone, but it's not. And our group has made several studies which I quoted today, and all these studies show that in vitro and also in clinical reality, if we use standard abutments and permanent cement, it is very possible that you won't be able to clean cement remnants. So in conclusion, implants with cement remnants in patients with history of periodontitis may be more likely to develop periimplantitis compared to patients without history. Cement remnants in patients without history of periodontitis cause less severe periimplant disease or may not predispose infection at all. And third, cement remnants could be considered as a predisposing factor for chronic periimplantitis development. And clinical implications, due to the data which we got, we completely changed the clinical way we practice in our clinical practice, and now if the patient has periodontal disease, we go for screw-retained restoration just to avoid any, let's say, etiological association between cement remnants and periimplantitis. And I want to thank you all, my team, and you for your attention. Thank you.
Thank you very much, Thomas, for the very interesting presentation. Do we have any questions from the audience? Yes?
First of all, I want to say you congratulations, because every year your presentations are even better. I remember in Athens was good, but this too has been much better. But I want to tell you something. Why, if there is almost what we have seen in your previous lecture, 90% of cases when we have excess of cement, when we go to the systematic reviews of periimplantitis, we don't find a statistically significant difference between cemented and screwed crowns or systems?
Yeah, that's a very good question, because there is no review which divided patients where they had history of periodontitis or not. There is no such thing. Other suggestion is that most of these reviews do not consider whether was permanent cement or temporary, because you won't have this if you use temporary cement, because it will wash out. And if there is no written which, because part of it may be cemented with temporary cement, and this is the reason why there are no complications. I think those two maybe explain it.
If you have to use temporary cement, which one do you choose? Do you prefer?
Bond.
Okay.
Any more questions? Yeah. I have a question. You showed that you had a control group with screw-retained prosthesis.
Yes.
For those patients, the prevalence of periimplantitis was very low. Did you implement for those patients a specific maintenance program, including the retrievability of the bridge in a regular way or not? Or was it they were treated in the same way as you have maintained the others?
Well, if we have, of course, in clinical practice, periodontal patient, the maintenance of it, it's more, let's say, more complicated and more frequent than non-perio patient. But these patients were not, let's say, applied to any specific, let's say, better cleaning or compared to patients with cemented restoration.
In other words, did you, in a regular way, did you retrieve the bridge every time you had a control or not?
No,
Never.
We did not retrieve.
Okay, thank you. That's very interesting information. Klaus, do you have any questions?
No, I was thinking a little bit about that we also sometimes have exposed implants surfaces when we don't submerge them enough. And when you look at also your pictures when you write that it's the bacteria because they will be retained, then I think it may be some of the same situation when you have an exposed implant because it may be even rougher than the
Cement.
yeah, than the cement. Have you been thinking about this or have any considerations concerning this with the exposed implant surface? Because I think it's a confounding factor in the studies.
Yeah, that might be a reason also. What the main message, I think, it's that, of course, it's not always cement. I just want, I think that we might just start to think that maybe that perimplantitis in some cases might be due to that. Not to exclude that factor at all, not even think about it. Because I remember in 2009 in the EAO in Monaco, I talked, there was some session about perimplantitis. I quite questioned, I also went to the lectures and we talked asked question about cement. So 3 years ago it was that cement does not even do anything. Other thing which is difficult, because you don't need big, let's say, pieces of cement to cause that. That may be, let's say, because usually when you have excess cement, it's like circular, like a ring of very thin, let's say, cement ring around neck of implant. So sometimes it may dissolve, something may be cleaned like during daily brushing or hygiene, but still already it may have predisposed like this reason. So the absence of cement does not mean that it was not there and did not cause that.
No.
Of course, it's like, go for the philosophical.
I'm sure there's a lot of confounding factors, but I think that also you examine the distance to the bone. That's quite interesting because that is a question of where do we have the preparation placed.
Yeah.
So I think it was very nice to see your presentation.
Thank you very much. I would like to congratulate all the presenters because it was very, very interesting, and I would like to thank you for your input. Thank you very much.
Thank you.